Hey y'all, welcome back to my channel. As told by Muriel, I am Muriel, and oh my goodness, y'all, I forgot to bring my books up here. I'm gonna just put a picture up here so y'all don't forget. I sell these Nurse Brain Creation report sheet booklets. I have them in green, pink, blue, royal blue, and light gray. They are report sheet booklets. They have sheets in them to help you do a thorough and accurate shift-to-shift report. This is for my specifically for my new grad nurses who are working long-term and acute care. Yes, I have them in long-term and acute care. I also think these will be good for agency nurses because, you know, we go from facility to facility. We work in different locations, and this way you can have your same sheet when you go. Like tonight I'm going somewhere. Yes, y'all, I'm working a night shift tonight. I picked up one with the agency. Tonight I'm going somewhere that I've never worked before, and so this sheet will come in handy. Say I'll go back to this place like sometime next week. If it's somewhere that I like, I'll have my sheet, so I'll know my residents. I won't have to keep asking questions unless something just happens to change. The booklets for long-term care are just like the basics on your patients, so that you'll know your patients who are blood sugars, who are diabetics, who are dialysis patients, who are peg tubes, if they take the meds whole, crush, things like that. It just covers the basics. And at the bottom of the sheet you can add little notes, you know, something that may can help you remember the patient if you happen to go back the next time. Like things like if you know this patient is blind, you can write down in the bottom in the notes, you know, patient in room so-and-so is blind. I suggest that things are written in these books in pencil. I know nurses don't really carry pencils too often. I myself, I went and actually bought some pencils and have not used a pencil yet in the books. But that's for the long-term care. That's because really things don't change that often in long-term care, but occasionally, especially if you're in a rehab hall, you might have a turnover of patients like every 2 to 3 weeks, because rehab hall, the patients normally don't stay longer than probably 120 days, I think is the longest. And sometimes they even become long-term care instead of rehab, and they move to another floor, and you may get patients who are only there for 30 days. Some might be there for 7 days for respite care. But as far as the long-term care floors, the patients are basically the same, unless you get one over, say, from rehab or something like that. But the acute care books are for those nurses who basically work in an acute care setting, acute, critical, whatever. It's for you to give an accurate and thorough shift-to-shift report, because there's a lot going on in acute care setting. Yeah, my nurse report sheet booklets, y'all. So I'm gonna have my link down below. You can order them from my Etsy store. Yeah. Anyway, y'all, as promised, I'm doing a video today on how to report a fall in a long-term care facility and how to document it accurately. Now, this is for long-term care, and I think it's a little different in assisted living, just a little different. But long-term care facilities, I'm going to show you how to thoroughly and accurately report a fall when it's witnessed and unwitnessed. There's only one change really when it's unwitnessed, but okay, so here we go. So I'm gonna give you a scenario. You come into work and you're working throughout, they're working throughout the day, and an aide comes and tells you patient Mrs. Jane Doe is on the floor. And you say, oh, did you see her fall? No, I didn't see her. The aide tells you, I didn't see her fall. She was on the floor when I went in the room. Okay. No one saw her fall. She's just on the floor. This is an unwitnessed fall, the most horrible of them all. So, as a nurse, you go in the patient's room. The first thing you do is you notice how the patient is positioned on the floor. You see if there is any bleeding or anything around the patient. And you talk to the patient. You ask the patient, are you hurting? And they say no. You ask them specifically, does your head hurt? Does your back hurt? They say no. Okay, for patients on the floor, what you're supposed to do, because most facilities you're not supposed to lift the patient. physically lift the patient, you're supposed to use a mechanical lift. Most mechanical lifts go down to the floor. If it's not apparent that this patient has any injury to their back or their head, use the lift to get them off the floor, because you really can't do anything with the patient on the floor. If the patient has an apparent injury to their back, call 911, because there could be some spinal injury going on. You don't want to mess anything up with them having a spinal injury. This patient needs to be log rolled and elevated off the floor. You don't want to injure their spine any further. I would just probably give them a pillow to put their head on, but not angle it up too high, because you don't want to mess up the alignment of their spine. I would call 911 to get them off the floor. I'd be like, the patient is on the floor, they're complaining that their back is hurting, and wait for 911 to get there and have them walk you through how to get the patient off the floor. But if the patient is denying any back pain, any head pain, you use the mechanical lift, you get them off the floor, you get them onto the bed. The first thing you do is get a set of vital signs. Those will be your initial vital signs. The second thing you do is you do an accurate body audit on the patient. So you get all of their clothing off, the nurse, and you look over their body. You see if there are any bumps, bruises, breaks in the skin, redness, swelling, any of that. One common thing in long-term care facilities when it comes to falls are hematomas and skin tears. So you check them over. Say you don't see anything. You don't see any bruising or anything. Okay, so that is notated. There's no bruising. You notice that. You did their vital signs. Now, with the vital signs, all facilities that I've ever worked with, an unwitnessed fall, you have to do neuro checks. This is because even if the fall wasn't witnessed and the patient said their head isn't hurting, they could have possibly hit their head. With head injuries is a chance of having an ICP, intracranial pressure, which is their brain will start swelling, decreasing the space between their brain and their skull. Sometimes this is observed in their vital signs. So you will, with their blood pressure will start to be elevated. They'll start losing cognition. They may be alert. Next thing you know, they're lethargic, then they're unresponsive. So we do vital signs on a certain schedule when it's an unwitnessed fall, just to check for possible ICP. Y'all, I took this from the job I worked today. This is one of the reasons I didn't want to do it yesterday, because I wanted to show y'all some of the paperwork, and this is the only thing I was able to snag. Y'all know I work agency, so it's not my facility, but this is an example of this certain facility's neuro check. It's called a neurological evaluation flow sheet. Okay, flow sheet. This form is like this. If you can see, oh, do I have it upside down? Okay. At the top of this form, you put the date, time, and your initials, just in the first spot. Okay. Each block will have a different time, because as you can see, is this showing up the right way for y'all? On the top of this form, you see those instructions. It says every 15 minutes. Every 15 minutes times 1 hour, you do your vitals. Every 30 minutes times 2 hours, you do vitals, a full set of vitals. Every 1 hour times 2 hours, you do a full set of vitals. Every shift for 72 hours. So that's 7 to 3, 3 to 11, 11 to 7, or 7A to 7P, 7P to 7A. That is how often and how long you will have to do vital signs on that patient when a fall is unwitnessed. They ask all these questions. Yeah, excuse me trying to read backwards, but all these questions here. You have to evaluate the patient and answer these questions regarding eye opening. Do they respond to spontaneous eye opening, which we do? We spontaneously, a person with no neurological damage, spontaneously. Do they respond to speech, to pain, or to none of these above? And it's which one do they respond to? Do they respond to, is it they're spontaneous? You would check, you put 4. If it's only to speech, you'll do 3. If it's only to pain, you'll do 2. No response at all would be 1. Next thing is verbal response. Do they sound, are they oriented when they speak? Are they confused when they speak? Are they using inappropriate speech? Or incomprehensible sounds. Okay, the difference between inappropriate speech is when someone is just saying like their speech is kind of not garbled, but like if you're having conversation with them and then they're just talking just, you know, crazy stuff that has nothing to do with what you're talking about, you know, inappropriate. It has nothing to do with what's going on. Incomprehensible means you don't understand what they're saying. They're trying to speak, but the words are just not, you're just not understanding. You can't comprehend. Incomprehensible. The next thing is motor response. So when you ask them, can you raise your right hand? Can you raise your left hand? Do they have appropriate, or do they obey commands? Or do they localize motor response to just one area? Do they withdraw from pain? So I hate to do this, but like on this one, I will like pinch their arm a little, see if they withdraw from the pain. Because that withdrawing from the pain, that's a motor response. Is that the only time you get a motor response? So that's withdrawals from pain. Abnormal flexion. We all know when you flex, extend. If y'all can see me, because I used to get so confused with extension, and even with the feet, do they flex inward? Do they extend outward? Flexion, extension. And also no movement. Do they have no movement at all? Now, not to say that these things here mean that they have, because that may have been their prior that might have been their prior response. That doesn't necessarily mean they got head involvement or any neurological damage, because some people don't have any of these responses prior to a fall. So, but if they don't have those responses prior to a fall, it should have already been documented somewhere in their admission or something, you know, that they didn't have these responses at all prior to. Just same as with the speech, same as with the eye opening. Sometimes these people have none of these responses at all prior to a fall, but then sometimes these people have these responses, and then later on, as you progress in time after a fall, they lose them. So that's why we track it as often as we do. As often as you do your vital signs, you have to track all these responses as well. Pupil size. It's good to have a pen light on hand, but you know, when I started nursing, it was all about the pen light. Now I just take my flashlight on my cell phone and I shine it in the eye, and I look for pupil reaction. If the person seems to be pretty oriented and alert and everything, I let them know ahead of time, hey, I gotta shine my light in your eye. I know you ain't gonna like it, but I gotta check your pupil response. They understand, because they know they had a fall. So you go ahead and I just shine my flashlight in their eye to see if their pupils react. That means it will constrict as the light gets closer to the eye, and it'll expand when you move the light away. So when you put the light in the eye and it constricts, meaning it gets smaller, that is a good pupil. That's a reactive pupil response. If it doesn't restrict at all, it doesn't expand, that's not a responsive. That's not good. That's not a responsive reaction for your pupils. Gag, swallow, reflex, swallowing or drinking, swallowing, or if they start gagging or anything, that means that it's still working. If they're swallowing and you can see the swallow, that's good. And then right arm, left arm movement, like I said, to see how their movement is with their extremities. And then the vital signs here. And this sheet is enough for a full 72-hour assessment. So every nurse that fills this out has to sign their signature, their initial, gotta have the resident's name. So this is what a neurological neurological evaluation flow sheet looks like. So after you've checked over the patient's body, you started these neuro checks, you have to tell your aide, look, this person got to get these neurological checks done. We might as well just leave the Dynamap, the wow, whatever you want to call it, vital sign machine, just leave it in the patient's room because we got to get these vital signs done. Once you do their body audit, and you don't notice anything, you don't see any bruises on their body. If they do have any open wounds or open anything, any bleeding cuts, you have to take care of that. If there is a tear and the edges can be approximated, which means you can put the edges of the skin tear back together, use steri strips. Clean the area, use steri strips to pull the skin back together so it can heal that way, and then possibly put an opsite over it, clear Tegaderm, opsite, clear dressing so it can stay in place. If it's a small little tear and there's not much skin isn't like torn away, just a little opening, I suggest just clean it with some normal saline, put some triple antibiotic ointment on it, maybe petroleum gauze, and then cover it with a dry dressing. Any areas, openings, you need to attend to those then, because say your patient is on aspirin or something, they can bleed out. Aspirin, Eliquis, warfarin, Coumadin, any of those blood thinners, they could bleed out from the smallest little cut or whatever. So make sure you take care of any wounds that you see. Ask the patient, are they having any pain? So you've done the body audit, you've addressed the caring for the wounds, you talked to the patient, you found out what happened. Now you call the physician, because you want to give all this information to the physician. Call the physician and you let them know, patient so-and-so was observed on the floor, no head injury, or there is head injury. Patient states pain to their back, or no, they don't state any pain to their back. Patient had a wound and this is what I dressed the wound with, or no, I didn't dress the wound, or they didn't have any wounds, or they do have a laceration. Neurological checks were started. Patient has reactive pupils or non-reactive pupils. You let them know what it is, and the doctor will give you instructions from there. Some of them might just say okay. Some of them might say, like if say the patient is saying they have an extreme pain to their right leg, their leg is hurt and you've already started observing some swelling, they may say get an x-ray of that right leg. Then if they do that, you can refer back to my last video on how to order x-ray. But anywho, they may say get an x-ray to that right leg, or they may say, well, this patient has a history of internal bleed, let's send them out, just to be honest. You never know what the doctor might say. Always call the doctor before you call the family. Call the doctor before you call the family. Let the doctor know, because he may give you some orders that you have to relay to the family. So then after you call the doctor, you notify the doctor, then call the family. Let the family know, hey, your mother, your father, your sister, your brother, your nephew, your cousin, whoever the RP is, was observed on the floor. They're stating pain or denying pain. They have this injury or don't have that injury. They we were able to transfer them to the bed and do their body audit, or they're stating that their back and their head is hurting. So we're waiting until 911 get to here to move them. Or what else did I say? We're started neuro checks and their pupils are not reactive, or their pupils are reactive. Their blood pressure is high and we're monitoring it, or their vital signs are stable. Patient stated they fell. This is what happened. This is what occurred. Okay. Now that you've done that, you have to fill out, during this whole time that you're doing this, you're still having to get all this on these neurological checks. That's going to be the thing, trying to go back and forth doing, unless you make all these phone calls from the patient room, you still have to be checking pupil responses. You still have to be doing all this stuff. Okay, so once you did all those notifications, you also have to notify your supervisor, whoever is your supervisor over the building. You have to call them and let them know there was a fall, because such things like this, some of them are reportable. I don't exactly know what is reportable, what is it, but you have to notify them about a fall. If the doctor says send him out, you have to notify him that the person's being sent out. You have to notify the supervisor. So then you finish your paperwork. So there's a form called a fall investigation form that has to be filled out. I wasn't able to snag one of those, but you're stating on there what happened. It's really redundant. You're putting the same things over and over. You're putting what happened, what occurred, what did you do to take care of it, what are notifications that were made. They're going to ask you like medications the patient took in the last 8 hours, because they want to know if the medications contributed to the fall. You know, were there any orders received from the doctor? Then you have to do a incident report. Incident reports are for the facility. These are reports that the facility uses to keep track of falls and things like that, any incidents, and to also try to figure out what can be done to prevent it in the future. This is an important part of any fall or any incident, because they want you to have an intervention to prevent these things from happening in the future. Interventions for falls could be anything ranging from keeping, like if the bed wasn't in the lowest position, keep the bed in the lowest position. If the patient was walking and fell, did they have on grip socks or grip shoes? Give the patient some grip socks. Was there adequate lighting in the room? Keep a light on at the patient's bedside. Was there water, or what else can I say? Putting fall mats on the side of the bed. That's an intervention. If some facilities still use bed alarms, maybe you need to put a bed alarm on the person if they fell out of the bed. That's an intervention. So yeah, you always have to have an intervention for an incident, especially a fall. So once you get all that paperwork done, there's a incident report, fall investigation form, witness statements. Even if no one witnessed the fall, everybody on the floor has to fill out a witness statement. If they didn't witness anything, say, I did not witness the fall. If it is the aide who observed the patient, observed them on the floor, they could state that I entered patient's room, patient was on the floor, I did not observe the patient fall. Everyone on the floor has to do a witness statement. And really that's about, and then put the note in the computer. You got to document everything that I just told you. You got a documentation. You got to put it in your, if it's a place that does written documentation, you have to put it in there. If they do electronic, you got to document it in there. The only thing that you do not document, you do not put in your charting that you did an incident report. That is not for the medical records. That is for the facility. If you happen to put in there that you did an incident report, and it goes to, and the family decides to sue or anything, and you put it in their notes that you did an incident report, they have a right to pull that incident report and have it as a legal record. So you do not put incident report documented. You do not put what you think happened. Oh, I think the patient fell out. No, you put what you observed and what the patient said. That is what you put. If it is a witness fall and the person was observed and they did not hit their head. I had this happen to me the other day. I was coming out of a patient's room and I saw another patient stumbling back, and then he went against the wall and he slid down to the floor. He was trying to get in his chair and he missed his chair. I witnessed that fall. I saw that the patient did not hit their head. The only part of this process I didn't have to do was this. If you witness the fall and they don't hit their head, you do not have to do a neurological evaluation form, which means I just do an initial set of vital signs, and that is it. No more vital signs are done. But the same thing goes with if they're complaining of back pain, they may have messed up their spine. I'm going to leave the patient there on the floor, call 911 and let them know, hey, I'm going to call the doctor first. Of course, we're going to call the doctor first, let them know patient is complaining of back pain, and we're going to leave it at that, because they may have fractured their spine. You don't know, and you don't want to mess anything up moving them. But if they didn't, like this patient, he went against the wall and he slid down. He didn't hit his head. There was really no spinal involvement. So I just did his vital signs. I still had to get him in the bed. I still had to do his body audit. I still had to do the fall investigation form. I still had to do the incident report. I still had to notify the doctor. I still had to notify the family. I still had to do the first neurological assessment, just that first one, which not the full assessment. I just had to do vital signs. So yeah, that is how you handle a fall, a witness or unwitnessed fall. I know I sound like I'm all over the place. I hope y'all can follow me. I was trying not to let this video be so long, Lord. It's 30 minutes, but so I'm gonna end it here. If I think of anything else, I will add it down below, but I believe that pretty much covers what you do in case of a fall. Please like this video. If you have any questions, put them down below. If this was helpful to you, or if you feel like I need to do it over, because I was all over the place. I'm just hoping y'all can follow along with what I'm saying. And I don't think I missed anything. That's about everything that has to be done. Please like, comment, and subscribe. I'm Muriel. This is That Soap by Muriel, and I will talk to y'all later. Bye.